A very good morning to all the judges and all the delegates. I am Dr. Sripada Sarweshwara, DNB second year resident, Maharaja Agrasen Hospital, and I am going to present a case on clinical, biochemical and radiological profile of primary hyperparathyroidism in a tertiary care hospital at North India. A primary hyperparathyroidism is characterized by excess secretion of PTH, usually due to autonomous secretion of autonomously functioning adenomas. The reason we took up this study is there are very limited data about primary hyperparathyroidism in Indian population. The aims and objectives of our study were to see the clinical, biochemical and radiological profile in primary hyperparathyroidism. Coming to material and methods, this is a retrospective study done in our tertiary care hospital over a duration of 2 years. This study has been approved by our institutional ethics committee. All subjects who were diagnosed with primary hyperparathyroidism and who were underwent parathyroidectomy were included in our study after taking their consent. Serum biochemistry parameters like calcium, intact parathyroid hormone and albumin were investigated using standard laboratory methods. USG ultrasound neck and sesame scan are used for the localization of site of the parathyroid adenoma. Statistical methods, analysis has been done using SPSS software of version 21. Coming to results, we had a total of 105 patients, out of which 24 were males and females were 81, who were histologically proven as primary hyperparathyroidism, out of which 5 were asymptomatic and 100 were symptomatic, with a male to female ratio of 1:3.3, and the mean age of presentation is 54.9 plus 12.8 years. And the age range of the age is 17 to 80 years. Coming to clinical and biochemical characteristics, majority of the patients were symptomatic, and the common clinical presentations include weakness, fatigue and nausea, vomiting, and other features like constipation, anorexia, AKI were seen in 40% and 14.2% respectively. These are the various presentations of symptoms, out of which weakness and fatigue are the most common symptoms, with third most common being the bone pain. And we had about 5 patients with low trauma fractures. And other less common manifestations like loss of memory and shortness of weight were seen in about 0.9% of the patients. Hypertension was prevalent in 22.8% and type 2 DM is prevalent in 12.38%. Coming to the biochemical manifestations, mean serum calcium was 12.01 plus 1.23 milligram per deciliter, and mean parathyroid hormone was 254.39 plus 269.76 picogram per deciliter. Coming to radiological manifestations, ultrasound neck and sesame scan were used for the preoperative localization of the adenomas. USG neck localized in about 98 subjects and could not be localized in the rest of the 7 subjects. Sesame scan localized the lesions in 58 subjects out of 80 subjects. We had a patient with ectopic gland detected in the superior mediastinum on MIBI, which was later confirmed as left parathyroid adenoma on ultrasound, and as operative finding, it was localized in the very low site of the neck extending into mediastinum. Out of the adenomas, most common was left inferior parathyroid adenoma, detected in about 45.7%, followed by right inferior parathyroid adenoma, least with the left superior parathyroid adenoma gland. These are the various locations of the tumors on the ultrasound neck. We had one giant parathyroid adenoma of size 6.2 into 2.8 centimeter, which was later came out as parathyroid adenoma on histopathological examinations. There were 2 patients with more than one parathyroid adenoma, and we had 2 patients which we could be able to localize the lesion in ultrasound neck, but that lesion could not be localized on system UV scan. Coming to the post-operative histopathological examination findings, all patients were underwent parathyroidectomy and resected tissue was sent for the histological examination. Out of the 5 asymptomatic patients, 4 were having the met the criteria of serum calcium more than 1 milligram per deciliter, and 1 was matched with the age criteria. The patient age was 48 years. These are the various histological examinations. Out of the 105 patients, 100 patients were diagnosed to have adenomas, 5 were hyperplasia, and 2 cases had double pathology of adenoma and papillary cell thyroid. We included one more new method like intraoperative IPTH. Usually this is done as 2 samples separated by 10 minutes, but in our study we included 1 sample which is taken at 15 minutes, covering the 3 half-lives of the PTH hormone, and we had a cutoff of 40 picogram per ml, which is the mid-reference range of our lab, 13 to 85 picogram per ml. Out of the 60 patients, we had 57 patients who had a fall to less than the 40 picogram ml at the end of 15 minutes, and 2 had still raised PTH after 15 minutes, and they were found to have hyperplasia on the histopathological examination. 1 patient did not have adequate fall. Coming to this, discussion, still PTH is the primary hyperthyroidism is the most still the symptomatic presentation. Coming strengths, we had a large sample size of 105 people. It's there, all the patients are operated by single endocrine surgeon and a single radiologist. Limitations was it's a retrospective study, no long-term follow-up. Coming to conclusion, in our study, we found the PTPH is still symptomatic variety. Single intraoperative sample would be economical. However, we need more prospective studies. These are references. Thank you.
You said large numbers are still symptomatic in our country, but you have included very non-specific symptom also in the symptomatic group, dyspepsia kind of thing or weakness, not bone pains, fractures or calculi.
As a bone pains were present in about 56%.
You said that there is no data of this from India, and that is why you did the study.
Very limited.
When you say very limited data in your review of literature, how many patients, how many series you found?
One major study was from PJ Chandigarh.
Only 1 series you found?
And other was from SGPJ Lucknow.
Only 2 series you found?
Some major.
I think if you look in the literature, there are at least 8-9 series from India. So why did you then plan this study? How is this different from what has been reported elsewhere?
So no, as such, no.
One thing which I can see very clearly, which is different from other studies, is you didn't seem to have any pancreatitis. You didn't describe any patient with pancreatitis among
Yes, pancreatitis was present in about 12%.
12% you
yes,
had pancreatitis.
Yes,
and you didn't have any parathyroid cancers also in histology?
No, sir. No.
You mentioned about cutoff of 40 PTH.
Yes, sir.
Those who have a significant high level of PTH pre-op, then sometimes it's difficult to reach 40 after removal.
This was only for the first 15 minutes. Covering the we had a cutoff for 15 minutes to cover the 3 half-lives of parathyroid hormone.
Sometimes those who have a pre-op PTH like 400, then
yes,
it might not able to reach up to 40.
Yes, sir. So that is, yes, sir, as of now, this is a very limited data.
You said ultrasound had 93% pickup rate. Sonography, you said had 93% pickup rate of identifying the adenoma, right?
94%, 98 subjects were picked up.
So can you tell me what are the sonological features of a parathyroid adenoma?
It is a hypoechoic lesion, usually localized to either superior pole or inferior pole of the thyroid.
Thank you.
Thank you, sir.